Okay, gives me pleasure to introduce our speaker. Dr. Mark Slaughter is an internationally acclaimed expert in heart transplant and mechanical devices that assist the heart in pumping. When I say international, he's traveled this past year over 90,000 miles doing his work. And I asked him, well, that's a lot of frequent flyer miles, and he said he doesn't have time to use them. So Dr. Slaughter came here 6 years ago as director of the Heart and Mechanical Assist Device at Jewish Hospital St. Mary's Healthcare. He's chief of thoracic and cardiovascular surgery at the University of Louisville. And he is both a clinician and a scientist. And his basic research is what makes the heart work what makes the heart work and how to help the heart when it needs help. He's implanted over 250 of these ventricular assist devices since he's in his career, and has actually done 50 heart transplants since he's been in Louisville, which is pretty tremendous. I asked him if he has time for anything else. He said, well, he used to play tennis. He's quite an accomplished player. He played in college for his school, and he played tournament tennis. And actually, he played at the junior clay courts here against some of the big names here at the Louisville Boat Club. He is a native of Indiana and a graduate of Purdue University with a degree in civil engineering. So let us welcome a civil engineer whose primary goal now is to help the failing hearts recover enough so that maybe they don't need a heart transplant. Dr. Slaughter.
Thank you very much. It's a real honor to be here. And I just was apologizing earlier. I was in Boston yesterday, and my flights got canceled. And luckily, my wife found some flights for me this morning. So I got up at 3 o'clock, got on some flights, and made it back. He was also telling me, though, I guess a few weeks ago, Dr. Boley was here and sort of had impressed everybody. And so midway through, I'm going to point out, competition's a good thing. And I'm going to demonstrate to you why we don't need cell therapy and we can grow heart muscle without it. Last time we were here, we talked a little bit about prevention and some programs that we've started to actually develop healthy lifestyles in our pulsive surgery program, because prevention has to start before you're 40, not with x-rays and screening tests. It has to start when you're a teenager. But unfortunately, once you get to be older, the fact of the matter is you have heart disease. And so what I really wanted to do is talk about some new technologies for treating advanced heart disease, and specifically what's going on here in Louisville. The other is, I think it's very important when you talk about what's going on in Louisville, as I've had the opportunity last week to speak at the University of Pennsylvania, and I actually gave the Julian Johnson lecture. And it turns out, so Julian Johnson was the first chief of thoracic surgery at the University of Pennsylvania, one of the oldest and most famous programs, and actually he was a native of Kentucky. So I say Kentucky reaches far throughout the world, and there's many people that have contributed. And actually this fall I'm giving a lecture for the Southern Thoracic to give the history of Louisville and its contributions to thoracic surgery. And I say I'm very excited as I continue to learn more about Kentucky and what is its contribution. So what I really want to sort of focus on today, and I'm going to speak relatively quickly, is heart failure. So unfortunately, everyone in the room, if you have breast cancer, or if you have cancer, everyone knows what it means. You go see a specialist and you go to a specialist clinic. Someone tells you have heart failure, and the answer is they give you some water pills, pat you on the back, and send you home. The problem is more people will die from heart failure than they will from cancer. You'll live longer if you have cancer than if you have heart failure. You'll live longer if you have AIDS than if you have heart failure. But somehow heart failure just flies under the radar. The other issue is heart failure is age-related. And as our population ages, and it's going to double by the year 2030, we're going to double the number of people who have heart failure. And we currently spend $40 billion on heart failure. And that does not include any therapies that actually will cure it. And what we're going to do is talk about a few therapies that actually will cure heart failure. And as I just point out here, the answer is no one believes a surgeon when they talk about medical therapy for heart failure. So this slide comes from the medicine book of heart failure, and you can see it's 100% fatal. So no one survives. So starting early in my career, the goal was, how can you cure an incurable disease? And we've made tremendous strides, and I think that a lot of it can be attributed to Louisville. So this is some information I stole from Dr. William Pierce. So Bill Pierce is at Penn State. He was one of the first developers of a total artificial heart, which it does turn out you actually don't need. You don't need to replace the entire heart with a mechanical heart. But he'd been at the NIH working for about 7 years when, about 1967, Charles Barnard did the first heart transplant. So they all ran down to him in his lab and told him, you've been working for 7 years, but you can go home. We don't need you anymore. And the fact of the matter is, and he has always said, though, is that heart transplantation has always been the greatest impetus to develop a mechanical heart pump. And here is the reason. So heart transplantation is wonderful. We like doing it. It's a fun operation. It's very gratifying. The patient and the family are very grateful. Overall, there's relatively low early mortality. 80 to 90% of people survive the first year, which is great. We always tell people they'll get about 10 years, but here's the real problem. So even though we've done about 80,000 heart transplants as a nation, this doesn't include Europe, the fact of the matter is very few people, there's only 120 out of the 80,000 that make it out to 20 years. So the problem is, if you're 20 or 30 years old and you have heart failure, which is half the population, they'll never live to be 40, they won't get married, they won't have kids. It's a problem. It's a great therapy if you're 55 to 65 years of age, and even then you can argue because everyone's living longer. But ultimately, this is not a solution for the people who have heart failure. So we have to find a way to have a solution for people that have advanced heart failure. So years ago, in Louisville historically was known sort of for the mechanical heart work for Dr. DeVries and then also certainly Dr. Lehman Gray. But it turns out you don't need a mechanical heart. A mechanical heart has not been put in now for about a decade. But what you can do is use miniaturized mechanical heart pumps. You don't need to take the heart out. So these are current trials in the early 2000s, still these people to get pills. And as I showed you, from the time you meet them, if they stay on pills, they're all dead within 12 to 18 months for those patients who have advanced heart failure. This is where we use pulsatile pumps, so they're a little bit bigger. They recreated a pulse. We tried to mimic sort of what the human heart was doing, and we did better than pills, but not okay. And then all of a sudden, we introduced miniaturized heart pumps, and these are patients that are in their 60s to 80s that weren't transplant eligible, and now, as you can see, the majority of them are all living many, many years and doing well. And actually, if you're a little bit younger, you have a 90% survival, which is actually as good or better than heart transplant. And that's from a few years ago. So what if you don't wait till they're nearly dying to put it in? What happens? So the idea is, as a rule of thumb, you transplant patients when they're not nearly dead. They have to at least be able to walk in. So this was Andy Boyle, and he's now at the Cleveland Clinic, but not to bore you with details. But these are patients that are in an ICU, relatively sick. These are people in an ICU just on IV medicine. These are people who have the same degree of heart failure but haven't required hospitalization yet. So their heart functions the same, they have the same symptoms, but if you don't wait till they're hospitalized, you actually have a 95% survival at 3 years. It's better than heart transplant using these miniaturized mechanical heart pumps. So Dr. Kirkland has always been my nemesis. He's at University of Alabama, Birmingham. His father was one of the giants in heart surgery. And Jim's actually a great guy. We get along very well. But he was always a skeptic. He actually has access to the database. For some reason, he controls all of our patients' information. And so he subsequently now has written a paper and has said that treating these patients with mechanical heart pumps is competitive with heart transplant out to 2 years. So even the skeptics at other programs now will agree that using mechanical heart pumps is essentially equivalent to heart transplantation. So this is from Duke. These are patients in their 70s. The blue line is patients that got a transplant. The orange line is people that got a miniaturized mechanical heart pump. It's identical. And these are patients that are elderly, not eligible for transplant. And the blue line doesn't include the patients when you're listed. 10 to 15% of people will die before ever getting a heart transplant. But we don't count those people because they never got the therapy. So what about here in Louisville? So shortly after coming here, we started sort of offering people the option. Some people don't have a choice, but rather than waiting till they're dying on the list. So this was in 2007 to 2009. And as you can see, our outcomes, we got lucky that year in transplant. Not a single patient died over a 3-year time period. And we only had 2 people that died who got a mechanical heart pump. And those people, 2 that died, one was actually died of diabetes. So the answer was it wasn't related to therapy. And the other patient was at home on their lawnmower, mowing the grass with headphones on, and he didn't hear the alarm go off that his battery was low. And unfortunately, by the time he recognized it, it was too late. So we can make some improvements, but the idea is these people are at home active and equivalent to heart transplantation. The other issue is cost. Everyone worries about cost. We can probably debate the Affordable Care Act all day long. But the issue is that people would never bat an eye with regards to cost for treating someone with heart failure. Well, this BTT, or using mechanical heart pump, is $196,000. We've published several papers now verifying this in multiple groups. So a heart transplant is slightly less, but it's only less because to acquire a human heart is $34,000. To pull one off the shelf, a mechanical heart pump, is $100,000. If I include biopsies and the drug therapy for transplant, they're identical. And in the next 5 years, the cost of mechanical heart pumps is going to come down in half, which means getting a mechanical heart pump will be cheaper than getting a heart transplant. So mechanical heart pumps aren't new. This was a patient of Dr. DeBakey's back in 1966. We knew they worked. They just weren't reliable. They were large. They were bulky. It was a problem. This is what we have today. So this is where I started. This was also very similar to the one you saw in the woman in 1966. These are pulsatile pumps. They sat outside the body. We then had pulsatile pumps that you implanted inside the abdomen. This is now a continuous flow pump, and you can see it's about 1/3 of the size. It's a magnetically suspended propeller. This is what we use now, and I was just in Belgium last week implanting this device. It is the size of a AA battery. And the answer is it will do the entire work of the heart. From this pump forward, any new pump entering a clinical trial in the next 5 years that we have done all participated in the device design and development over at the Cardiovascular Innovation Institute. So this is the one pump you saw in the third one. These are the 3 that we've developed since. This is the propeller that rests inside this pump called the Heartware HVAD. It's now been miniaturized, and this is the size of the spinning propeller. So once the propeller is this small, we can now miniaturize the chamber and have multiple configurations. So we just want to show you a couple, but once again, here's the one actually we put in, was it Monday? So Monday we did one, and we have another one tomorrow. This will be the new size. I'll show you a couple pictures. But the idea is we can now change it where we don't have to sew anything else on. We can stick a needle in the tip of the heart, put a guide wire in, and just slip it through the tip of the heart. It goes across the valve, and actually it just assists the heart and actually will do all the pumping. So you don't have to take the heart out, you don't replace it, you don't do anything else to it. Here's a picture. You can see an experiment that we did. You literally put a needle, a guide wire, you just slip it in and you turn it on. You don't need to go on bypass, as I'll show you in just a second. You don't need to split the sternum, and it's not a big operation. But more importantly, the idea is what we'd like to do is avoid heart transplant altogether and ultimately use the pump to recover the heart, take the pump out so that you don't have a pump, you don't have a transplant, you go home and get on with your life. So this is a normal heart. It looks like the shape of a football. This is heart failure. It doubles in size. It gets round. It's very inefficient and leads to symptoms. I'm not going to bore you with the details, but putting a pump in not just flows blood. It turns out it changes the neurohormonal system of the body such that the body can recover and creates an environment in which the heart can work better. And this is just a few slides. This is some heart muscle. You can see they're very big and round. You only see a few purple dots. Those are nuclei. You put the pump in, take it out, and now the muscle is reorganized. It's small, it's in sheaths, and you see all the purple nuclei again. So putting the pump in genetically also changes heart muscle. And this is another example that we'll come back to in a second, but the idea is red is good, blue is bad. Blue is scar, blue will never move. So the idea is you put the pump in, you turn it on, you take it out, and a lot of the blue is gone. So the answer is, why can't we put pumps in, let the heart rest, and then just take them out and never even have to transplant anybody? So the issue has been is we really didn't know how to run the pumps. So we spent the last 4 or 5 years working on this. And the idea, though, is here's the patient with the pump in and running. It's called a pressure volume loop. So it sort of shows you the pressure in the heart where it is. But the only reason why I show it is the idea is depending upon what speed I set it, you can see it changes the volume in the heart and the pressures in the heart. So before, we just put it in, turned it on, and thought that the higher speed, the better, and the answer is probably not true. This actually shows the blood flow in the heart. So this is heart failure. This is actually if we have the pump at full speed and you have almost normal blood flow, right? So you have to get rid of that blue, the scarring, and not let it occur anymore. This is if you run it somewhere in between. So the problem is if you don't run it fast enough early, you don't have enough blood flow and you'll form more scar. So we want to run it fast at first, then start slowing it down once it's recovered. So I actually, I'll say, was sort of on the wrong side of the fence originally when we developed these small pumps. When you put them in and turn them on, you become pulseless. So the biggest problem we had was in the hospital and sending people home, no one had a pulse. People would actually get dizzy at home and pass out, and they would start doing CPR, and the patient was absolutely fine because you can't find a pulse. And we thought, well, you're fine, you don't need a pulse. And the fact of the matter is you do okay for a prolonged period of time, but there's probably a reason why human beings have a pulse. And as you can see here, it does multiple things though. And the idea is it's not we just have a pulse, it's sort of bounding. But if you think of it as this is a blood vessel, these are little cells that line it. And when you get rid of the pulse, those cells quit working. What happens is the blood vessels become very stiff, they become rigid, and it makes it hard for the heart to recover because now that weak heart has to pump against a rigid pipe. So we were actually taking a patient who might recover and converting their vessels into rigid pipes unwittingly. So the idea is you can't just turn it on because this becomes static and all these cells quit working. So we have to find a way to make this continuously spinning propeller pulsatile. Well, the idea is we can do it. And we submitted actually a patent a year and a half ago. So if you think of a pulse and your blood pressure, and the idea is sort of this is, 140 over 80, and this is somewhere around, sort of 80 over 50, some of that range. So here's a healthy heart. Here's what happens when you have heart failure. When we put in a pulsatile VAD, one that actually pumped blood, the idea is we way overshot, which also wasn't very good. We didn't know it at the time. When we put in a continuous flow VAD, we came way down here, actually worse than heart failure. So we have to find a way to make it equal to a healthy heart. So the idea is we can go way up here, we can go way down here, or we can make it equal. And the fact of the matter is we can do it. So you start with what's called a mock loop. So this is a human being made out of plastic tubing. But the idea is it mimics all the chambers of the heart, the blood pressure, the valves. And the idea is then you can start doing experiments and determining how you can make that continuously spinning propeller make a pulse. And here's what happens. So this is if I turn it on, this is what happens. So now we have a new algorithm, a software program that actually will have 16 or 19 beats per minute, or you can make it at 60 cycles. The idea is you can start altering it and make that propeller go fast, slow, and change the timing. Once again, the idea is this is if you just turn it on, you make things a little bit better, but as I showed you before, moving this way is better. So it turns out, this is if you time it to the cardiac cycle, and I say I'm not going to bore you with the details, but the idea is it turns out you don't have to time it to the heart cycle. So you don't need a pacemaker, you don't need anything else. And what I can do is I can do the 19 cycles per second, and not only do I reduce the volume, I shift it to the left, so the heart's not doing any work, it's getting extra blood flow, and it can start to recover. So this is where it gets really interesting then. So the question is, why don't more patients get better? And we've taken out about a dozen pumps over the past 12 months. So relatively young people in their 50s, they were going to die. They were put on the transplant list. We put a heart pump in them, and then 12 months later, we take it out, and their heart functions normal. But the question is, why can't we do it more often? Well, too many of them have too much blue. So the red part gets a little bit better, but the blue part doesn't. So this is where Dr. Bowley and I differ. And he's a tremendous scientist. But what a lot of people want to do is try and take a bunch of cells and somehow think you can inject a random bunch of cells, like a bag of BBs, and somehow they're going to align, make muscle cells, make electric cells, make ventricle, atrium, realign themselves and create a heart. Well, the extreme of that is, this is Doris Taylor, who was at Duke, University of Minnesota, and she just now moved to the Texas Heart Institute. And the idea is, well, you take a heart and you can use a special detergent and you wipe all the cells out, right? So you're left with sort of the skeleton of the heart. Then the idea is you inject these progenitor cells, let them grow, and quote, grow a new heart. The fact of the matter is, though, it doesn't work, and they've been trying for 20 years. You can make it red, you can make it about this big, and it'll wiggle in a photo, but it'll never ever pump blood, because the heart is much more complex than that. So my argument is, why do I want to do anything else to that red area? Red is good, and I can make it better with the heart pump. All I need to do is replace the blue. Well, with the heart pump, I already showed you I can make most of the blue go away. So now all I have to do is put something right in this blue area that will then form red and actually join this, and you'll have a normal heart again. But it has to go right in the blue area. It can't just go everywhere. You only want it in the blue area. The other problem with just injecting cells is you want it to go in that blue area. And that blue area is not normal. It's very hostile. It's scar. There's no blood vessels in it. So why would we ever think you can take a healthy cell, put it in a hostile environment, and somehow it's going to be happy, grow, and form normal heart muscle? So what if I can make that blue area a happy blue area? So all I want to do is make it happy. And if I can make it a happy blue area, we have naturally occurring progenitor cells that are already in our body. We know it. That's what Dr. Boley does. He goes and finds them, then grows them in a dish and puts them back. And it's very important work. But the idea is our bodies, they're already there. They just need an environment in which they can grow. So the first thing you have to do is create a real model of heart failure. So this is an animal model of heart failure. So this is a normal looking heart, and we inject microspheres and we create heart failure. So you can see over time, left ventricle is all scarred, right? So the white would be blue when you stain it. That's what this is when you stain it. And here you see other blue. The right side starts getting big, and this is heart failure. And actually the animals die within 3 months if you don't treat them. So it's identical to human heart failure. So what we did is we use what's called extracellular matrix. It's the blue area. So you can actually, we found a way to emulsify it so it becomes injectable. It's not liquid, but it's chunky, but you can still inject it. But it is acellular. So you make a paste and you can directly inject it in those blue areas. We don't use cells. The idea then is use the pump, let it rest, and natural cells will populate it and you'll grow new heart muscle. At least that's our theory. So the idea is the LVAD, or the ventricular assist device, is the platform for myocardial rest, for letting the heart rest. They will then use extracellular matrix and will count on the body to repair itself. It's what it's been doing for 40 years. Why would it quit? And this will be a synergistic effect. So first of all, we have to develop a tool. So we did this with Core Matrix. So it's a pneumatic delivery tool, so we can now inject this material to a specified depth. We can use a special echo machine where you can identify the blue area. And so you do an experiment. So this is a normal heart. This is a heart failure heart. This one is with the VAD only. This is with extracellular matrix only. Remember, no cells to start with. And this is the VAD plus cells. And basically, it's become a normal heart again. So what happens to end organ tissue? You don't have enough blood flow. And once again, as you can look at any organ you want, and the combination is better than either one alone. And we know VADs work pretty well, but VADs plus this magic goo work even better. Here's the scarring. So this is with the LVAD only. It got smaller, but not small enough to take it out. This is with ECM only, smaller, but not enough. This is VAD plus ECM. So here's the real kicker. So and you've seen very similar sides from Dr. Boley. So you take that tissue, right, that was originally scar and dead, and you do special stains. So the blue are the nuclei, right? It's what drives the cell, right? It's sort of like the home of the cell. So white is what we stain with BRDU. So these are new cells. These are heart muscle cells. And so the white overlying the blue means these are all new heart muscle cells. And we didn't put a single cell in. So the idea is by creating an environment, by replacing the blue with a happy home, the body will repair itself while a mechanical heart pump allows the heart to rest. And once again, this is the most number of new cells ever shown in a heart failure model, and we didn't put a single cell in. And we presented this a month ago at the International Society of Heart and Lung Transplant. So what about these operations? No one wants a heart operation, right? They always tell you that to split your breastbone, you know, the heart-lung machine, all those things, right? We still do it sometimes, but here's how we put mechanical heart pumps in now. You don't need a total artificial heart. We make a 6-centimeter incision on the left chest wall, right up here at your manubrium, sort of at the sternal notch, and we're able to put the heart pumps in through these 2 small incisions. And this is what it looks like when you're done. So the answer is, with the new technology, not only is it getting close to or equivalent to heart transplant, but we can do it through small incisions, not on bypass, and we're getting very, very close, and the company hates it when I call it goo, but the answer is we'll be able to start adding goo and actually recovering hearts, taking the pumps out, and never need to transplant anybody again, and have a cure for heart failure. If you can hit the pump, or the slide. So the other is, so as you saw that one slide where we made the incision and you see the ring on, wouldn't it be nice if we could have a tool where, once again, all we do is core a hole in the heart, basically create a port, have a cap, so we can now just stick it in. So this is something that we worked with APK. It's a company now out of Ireland. They were just here last week. It was all developed here in Louisville. We actually got them a grant for it. Because of the grant we got for them, they got the entrepreneurial company in Ireland for the year, and they just sold the device for a lot of money. And it was all developed here. So it's a single tool. You make a hole in the heart. You don't need to go on bypass. You don't need blood thinners. And it takes less than 10 minutes to put a heart pump in. So this is now what it looks like. I say it's real life. We do it every week. And the other is, the idea is sometimes, though, too, when you're working through small incisions and you can't see everything, you want to make sure it's oriented properly. So there's another tool that's been developed. And let me see if this one works. Yeah, this one goes by itself. So the idea is there's ways now to start altering these so you can get the absolute perfect position. So here's another ring that's developed. You can just screw it right in the tip of the heart. You put this miniaturized pump in. It does the complete work of the heart. It flows 10 liters per minute. You can now slide it in and out, change the angle, set it however you want, and then tighten the screw. So what does this mean for transplantation? Because going back, remember, heart transplantation is the gold standard, and they told Dr. Pierce back in 1967 to go home because they didn't need mechanical heart pumps. So this is a series of papers that we've published in the last 18 months. So what does having a left ventricular assist device do for those patients on the heart transplant waiting list? Because I told you 15% of people die while waiting, and the other ones are all bedbound, short of breath, swollen legs, and can't make it to the bathroom. Well, it turns out these are patients on the heart transplant waiting list that have a heart pump. These are the ones without it. So the idea is you live longer and have a better chance of making it to heart transplant if you have a mechanical heart pump. So what happens to those patients that have one? You might say, well, gee whiz, it's a harder operation to go back. You have to take it out. You know, there's always lots of critics. So this is using the National UNOS database. This isn't just Louisville. This is every transplant program in the country, their data. And it turns out that the first year, the outcome's the same. And after the first year, you have a better survival if you had a heart pump than if you didn't. And the reason is you're healthy when you go to heart transplant. You're at home, golfing, working, doing whatever you want, and you stroll in the hospital. If you don't have a heart pump, once again, you're bedridden, swollen with bad kidneys, and then you're expected to do well afterwards. So the other thing that we've had a problem with is nowadays is there's not as many donors, right? We still only do 2,000 heart transplants a year, and the number of people on the list continues to grow. At the moment, I think there's 6,000. So the idea is to maintain your Medicare numbers so you can keep the program open. You now accept hearts that you would never have taken 10 years ago, or what we call a marginal donor. So what happens then if you take a marginal donor versus getting a heart pump? And the fact of the matter is you do just as well with a heart pump, and you didn't have to sit around waiting with heart failure. So I think it's very exciting times, and everything that I showed you today has been developed here in Louisville, and I think it's incredibly exciting. So in conclusion, in medically speaking, morbidity and mortality from heart disease continues to decline. Heart failure is a huge problem. Dr. Boley's an important part of it. I steal most of ideas, simplify them, and then use my heart pump to make his ideas better. So anyway, but more importantly, I say Louisville continues to be a significant national and international contributor to the advancement and development of new cardiovascular therapies, and probably most importantly, and I never do it often enough, I couldn't have achieved half as much without the support of my wife.